PCIs, otherwise known as percutaneous coronary interventions, otherwise known as your coronary angiogram, aka cardiac catheterization, and that could also lead to something called a percutaneous coronary transluminal angioplasty. Now, we talked about pulmonary angiograms back in respiratory. This is very, very similar, except now the iodine-based dye is going to be injected into the coronary arteries to visualize for any blockages, any narrowing. And also, during this procedure, we can, as part of that process, there could be a balloon on the end of that catheter where if we locate an obstruction, we can inflate the balloon and smush that obstruction, that plaque, up against the inside of the coronary artery, creating an opening in that coronary artery where the blood flow is improved. We can also place a stent in that newly opened coronary artery to help to preserve that, to make sure that it doesn't reocclude or spasm and close off. In the case of a cardiac cath, we may insert that catheter through the radial or femoral artery, depending on the patient. And then our pre- and post-procedure care is talked about in Chapter 14, Table 14.3 and Box 14.4. And also everything that we talked about when it came to pulmonary angiograms. One of the things that we do have to be concerned about after a PCI cardiac cath are some cardiac dysrhythmias. The heart doesn't take too kindly to the fact that a catheter has been inserted in the coronary arteries, iodine-based dye has been injected there, balloons have been expanded and blown up. So dysrhythmias can occur. We need to watch for any of those dysrhythmias. And check your PowerPoint notes for all of the different assessments that you will have to do after this procedure. And here's a picture of the balloon angioplasty, the PCTA. A coronary artery bypass graft, you may hear it referred to as a CABG, and this can occur when a PCTA is not effective, thrombolytics are not effective, or they may need to just go right to this particular procedure to bypass areas of occlusion that cannot be opened up by traditional means. Frequently, our patients are put on a bypass machine where their heart is stopped, and this machine takes care of their blood circulation so that they can operate on a heart that's not moving. We can also do something called off-pump CABG or mid-CABG, mid-cab, where the heart is slowed down. The patient is made hypothermic, and the heart rate slows so much that we're able to operate on it in between beats, essentially. Oftentimes now, patients do not have to have major open heart surgery to do bypass grafts if we have anteriorly located occlusions that need to be bypassed. They can be done through smaller incisions. But postoperatively, if our patient has had open heart surgery, they've had their chest cracked open, we will have mediastinal chest tubes to drain any fluid or blood that's accumulating. You treat those just as you would those chest tubes that we talked about with our respiratory patients who have chest tubes placed in the pleural space. We need blood pressure support. The heart is very weak after this surgery. We need to make sure that it can pump effectively, so various vasopressors and positive inotropes will be given to help that heart pump effectively. And we need to titrate those so that the blood pressure is not too high, which will cause further stress on an already damaged heart, but it's sufficient for good homeostasis. And how we do that is through various ways of hemodynamic monitoring, the pulmonary artery catheter, and arterial line that we're going to talk about in our next video. They may need blood transfusions. They are definitely going to need to watch electrolyte levels, so watch your labs very carefully. Several different electrolyte imbalances can cause cardiac dysrhythmias, particularly potassium. We really watch that potassium. Hypokalemia can lead to PVCs, premature ventricular contractions, which are very, very dangerous for the patient who has had a CABG and who has also had an MI, which we're going to talk about in a few minutes. They will probably be on a mechanical ventilator for a few hours post-op. They're going to be in critical care, and we're going to be doing hourly assessments that I have listed in the PowerPoint notes pages, and complications that we're going to be monitoring for, both on the table in Chapter 14 and also on the PowerPoint notes pages. So now let's look at the patient who's had an MI, a myocardial infarction. And this is a scenario where that occlusion or narrowing of the artery is so significant that there's no oxygenated blood flow to the myocardium, and there is actual physical damage, death to myocardial cells. That is a myocardial infarction. Assessments is talked about quite significantly in Chapter 14. There's a box 14.5 and on page 445. Always remember with MIs, time is muscle. The sooner they get to the hospital, the sooner we open up that coronary artery or arteries, restore perfusion, the less damage will continue to occur. We may not be able to reverse the damage that has already occurred, but we can prevent further damage from occurring. So look at those, think of those presenting signs and symptoms of patients and differentiate between what's happening with just angina or when it has progressed to the point of an MI. And know what the differences are with female patients. Many female patients will not have the traditional signs and symptoms that are kind of the classic, the crushing chest pain, the jaw pain, the arm pain. Many times, female patients will have some upper back, some scapular discomfort, fatigue, shortness of breath. And because most patients who experience MIs are in denial about the fact that they're having an MI, oftentimes these female patients that are having these vague, non-specific symptoms are kind of blaming them on other things that have been happening in their lives. They didn't get enough sleep, they spent too much time on their computer, their neck is a little stiff. So teach your female patients that this can occur as a different sign or symptom of an impending or occurring MI. We're going to be looking at classic changes in EKGs. We're going to talk in a lot more detail about EKGs when we get to dysrhythmias. So I'm going to show you what a normal EKG is and explain a little bit of what happens when there's been myocardial damage and what changes that can happen. Review what an echocardiogram does. What does it evaluate? What are we looking for in that patient who has had an MI or is having an MI currently? So let's look at our normal EKG. First of all, think of this, what we call the isoelectric line, which is kind of an invisible line that goes along where my cursor is moving. The P wave is indicating atrial contraction. The QRS is your ventricular contraction. The ST segment, which we're going to talk about in a little bit, that is from the end of ventricular contraction to the beginning of diastole, relaxation. And the T wave is what we're going to see during diastole. So that's your normal EKG. Now, if the patient has had an MI, they may have a T wave inversion. So here's the normal T wave on the left. It is above that isoelectric line. When there's been myocardial damage, they could have a T wave inversion where the T is below the isoelectric line. ST segment elevation. So normal, it's nice and straight and flat along the isoelectric line. With myocardial damage, it is elevated, as you can see here on the right. Or we may have an abnormal Q. A normal Q, the beginning of the QRS complex, ventricular contraction, is a very small, narrow notch below the isoelectric line. And here's a pathologic Q wave indicating myocardial damage along the conduction pathway. It's wider and it's deeper than the normal Q wave on the left. So those are some of the things that we look at when we're having a patient presenting with symptoms and trying to determine if they are having or have had an MI. Now let's look at the labs, the cardiac markers. We have CK and the isoenzymes, we have myoglobin, and we have troponin. CK and the isoenzymes and the myoglobin are a lot trickier. They will be indicating myocardial damage, but they can also indicate damage in other areas of the body, specifically skeletal muscle for CK and myoglobin, which can happen with crush injuries, rhabdomyolysis, those sorts of things. So with a heart attack, what we're looking for is changes and elevations in an isoenzyme, a subcategory of the total CK. And we look at the CKMB, the myocardial band. And it's expressed as a ratio to the total CK. And if it's elevated, that indicates myocardial damage. On the new NCLEX, they're going to give you the reference ranges. So you'll know if it's elevated as it relates to the CK, the total CK. Myoglobin, again, you don't have to memorize the normals because it's going to be given to you on the NCLEX with those reference ranges, but it can be found in cardiac and skeletal muscles. So we look at it, but it's not the definitive test. The definitive is troponin. It's located in the myocardial muscle. It's released into the bloodstream with injury to the myocardium, and any elevation is indicative of some damage to the cardiac muscle. And it can stay elevated up to 3 weeks. So we can determine if that patient had an MI a while ago by doing a troponin level, even if they're not actively having chest pain today. And now our goals with managing myocardial infarction. We have to limit myocardial damage. Remember, time is muscle. The sooner we open up that coronary artery and restore perfusion, the less damage is done going forward. So we may need thrombolytics, we may need a PCTA, we may need a bypass. Anything that's going to restore perfusion, the flow of oxygenated blood to that myocardium. We need to relieve symptoms. So think of Mona, your friend Mona. Morphine to reduce pain, oxygen to improve perfusion, nitroglycerin, a vasodilator, which opens up the coronary arteries, and ASA, aspirin, which prevents the formation of new clots or anticoagulants. So Mona is going to help relieve symptoms. We need to reduce cardiac workload, and we're going to do that by reducing preload, the volume of blood coming back to the heart, and afterload, the resistance that the heart has to pump against in order to get oxygenated blood out into the periphery. So to do that, we're going to drive our SOB into the emergency room. We're going to give statins to reduce atherosclerosis, so that's going to help to resolve some of the blockages. ACE inhibitors, which help to reduce afterload, and we're going to talk about some of these medications on our next video. Aspirin or anticoagulants, and beta blockers, another blood pressure medication that reduces afterload and slows down the heart and helps to reduce cardiac workload. Diuretics are going to be given in order to reduce preload. And then we manage complications. The biggest potential complication is a fatal dysrhythmia. So watching our electrolyte levels is very, very important. Just like we talked about with the CABG, watching that potassium level in particular. Hypokalemia leads to premature ventricular contractions, which can lead to ventricular tachycardia, an atrial fib, cardiac arrest. So keeping that potassium level kind of on the high side of normal, because a lot of these patients are going to be on diuretics, and those are going to deplete your potassium. We're going to do vasopressors, medications that can help manage that blood pressure, keep it high enough so that we have good homeostasis, good cardiac output, but not so high that it causes further damage to the myocardium because the heart has to pump really hard against that resistance.